the time period for public comments, and we will not be monitoring the chat function during the meeting for public comments. However, we do encourage public comments to be sent via email to mv.maryland.coph@maryland.gov. Once again, comments to mv.coph@maryland.gov. We also ask members of the commission who are online now to mute your microphones while not speaking, just to help us be able to hear each other here. And please use the raise hand function to indicate that you wish to speak and that you will then be recognized. Individuals who serve on the commission are subject to Maryland public health, Maryland public ethics laws, and all have confirmed their agreement to this in their application and listed any conflicts of interest. There are attendance requirements for individuals appointed by the governor, and the members know of this. And this attendance requirement does not apply to ex officios. And obviously there are waivers to this, and people can send in the ability to attend either online as opposed to in person, or to miss a certain number of meetings. I will not ask Michelle Kong, who has played a quintessential role in the organizational aspects of the Commission on Public Health, and is one of my key members of our team at the University of Maryland School of Public Health, to call the role of the commissioners. Please.
When I call your name, please respond yes or here or present. Heather Bagnall. Camille Blake Fall.
Here.
Christopher Brandt. Jean Drummond. Nilesh Kalyanaraman.
Here.
Alyssa Lord. Fran Phillips.
Here.
Nicole Rochester.
Here.
Mara Rossman. Michelle Spencer. Alan Twigg.
Here.
We have 8 members present.
Okay. And just for the record, Boris Lushniak is here. Anyone else who hasn't been called?
Oluwatosin told you.
Thank you, Tosin.
Sorry, Tosin.
No problem.
So final numbers?
8.
Okay, 8 total present, which gives us a quorum. Thank you. We are now functioning actually as opposed. I mentioned 16 members of the commission. 2 have left that had been appointed by the governor, or appointee from local health department, and appointee from the Senate. We are still waiting on a reappointment of those. So we will be functioning with a total number of 14. 8 out of 14 makes our 51%, 50 plus 1, 50% plus 1. So we have a quorum. The agenda has been posted and distributed to the commissioners prior to this meeting. I do want to make one modification prior to us voting on the agenda, and that's this time, one of the things that I found that as we're doing these meetings is we really limited some of our presentations to 30-minute time slots. And I find that sometimes we're rushing through some of the questions and the ability for us to get through. We're modifying it at this meeting where we're going to have 2 presentations back to back of 45 minutes. So that allows the commissioners and us to question and to be able to have a good, and all the speakers say the same thing about it. It's not a surprising thing, which is they're not here to talk to us. They're here to engage with us. So today we're going to try a new experiment in terms of the agenda. We'll have both presentations at 45 minutes in length back to back, and then we will have a break. So the modification from the agendas you received is that we're moving the break from Roman numeral 8 to Roman numeral 7, and then after the second presentation, we will have our commission updates and announcements and other matters before the commission. So with that modification, I ask that the agenda be, that a motion be set to approve today's agenda. Fran moves. Jean Drummond seconds. Commissioners, all in favor of the agenda as set up, please say aye.
Hi.
Anyone against the modified agenda? Any abstentions? Okay, so we move with the agenda. We also, per our routine of being a commission, an official commission, also post our minutes from the previous meeting ultimately, so that to the public, you can see the minutes of every single meeting. We do not post the meeting minutes until they are approved by the commission. And so therefore, the commissioner should have received the minutes from the previous meeting on June 6, 2024. They were posted and distributed. First of all, are there any comments or modifications to the minutes that have been distributed? If there are none, do I have a motion to approve the minutes?
I move to approve the minutes.
Great. Jean Drummond moved and seconded by Tosin. And all those in favor of the minutes being approved, please say aye. Any any against? Okay, and any abstentions? Okay, minutes have been approved and they will be posted on our website. Today, we have two special guests. As I mentioned, we're going to start off with saving the business portion of our meeting for the latter part of the meeting. We do ask if Mark, if you want to stay, obviously, for the meeting, please do so. We'd love to have you here. And our second speaker as well. And I'll be introducing both speakers shortly. But actually, let's begin with Mark. Mark Luckner is, first of all, a friend of mine. From the School of Public Health, was one of our faculty members, was involved in our Horowitz Center on Health Literacy, and it holds a very important position in the state. He's the executive director of the Maryland Community Health Resource Commission, and this is a position he's held since 2009. So this is a person with an incredible amount of knowledge based upon what's going on within our state, and one we obviously needed to reach out to from our commission's perspective to get a sense of what's going on in terms of our community and the health resources put into that. This CHRC was created by the Maryland General Assembly in 2005 to expand access to affordable, high-quality health care for underserved communities and help bolster the capacity of Maryland's safety net providers. CHRC has awarded 846 grants to date, totaling $282.3 million, supporting programs in all 24 jurisdictions of the state. And these programs are quite varied. They've provided healthcare services for more than 628,000 Marylanders, and grantees have leveraged $44.7 million in additional resources. In addition, CHRC is currently implementing the Maryland Health Equity Resources Act, which provides $59 million to reduce health disparities in Maryland. Also supports the Maryland Consortium on Coordinated Community Supports, which was created by the Blueprint for Maryland's Future to expand access to comprehensive behavioral health services for all students throughout the state. And more than $115 million has been provided to the consortium to support new and expanded programs in all 4 jurisdictions. As for Mark, before coming to CHRC, he served as Senior Policy Advisor on Healthcare, Human Services, and Public Safety issues for Governor Martin O'Malley's State STAT program. And prior to working in the governor's office, Mark worked as a legislative aide in the Maryland House of Delegates for 8 years, 6 years as an assistant to the chairman for the Health and Government Operations Committee. He got his BA in American Government from Georgetown University and a master's in American Government from Johns Hopkins University. Let's give him a warm Commission on Public Health welcome, Mark.
Thanks. Most important of all that is your friend, and it's great to be involved with our great friends. So,
Great. Can we get a volume check on Mark's voice?
yeah, probably need to project. Okay,
Dane, give me a volume check on Mark's voice.
but that's okay. Can you hear me?
It's a little soft.
Okay. Yeah. Okay. Well, thanks for that, Dean. You gave a great overview of the growth Maryland Resource Commission, due in no small part to our great friends, Maryland General Assembly. So thanks for that. I'm going to cover these topics for you, a little bit about the background of our commission, the impact of our grants, and then I'm very excited to talk about 2 new programs, new in the sense of not 16 years old. the Maryland Health Equity Resource Act. I think I saw that Camille was on the call, so thanks again for serving on our advisory board. I also want to thank the Shelter Township who also served on the advisory board. It's a great group of folks that are highly motivated. We lean on them for their expertise and diversity. We're going to talk about that in great detail. And then after that, I'm going to talk a little bit about the consortium on coordinated supports, which, as you said, Dean, was created in the blueprint bill. And then once we get through that, I'm going to maybe throw up a couple of softballs here, since we baseball season. Next we can talk about together.
Sounds great.
Okay, thanks again.
And if there's any issue of hearing him, Mark, the other option is to do it at the podium where the microphone is much better. So,
Okay, well, I'll try from here and then, does that sound, okay. All right, I'm sorry. Okay, great. So yeah, you have here the list of our statutory responsibilities, and I'm not going to read each of these, but I think as the Public Health Commission goes down its journey to look at all the nooks and crannies in the state of Maryland, which is diverse and unique and so forth. I think if there was one thing I might say that I would suggest to the audience here is that the commission was created by the General Assembly to focus exclusively on the safety net providers and the special populations in the future. And that mission has evolved over time, as one might imagine, but it's led to the General Assembly asking us to launch 2 new initiatives over the last couple of years. But the important point is that we're the part of the executive branch that focuses exclusively on those special populations of underserved. And everything we do is about meeting that statutory mission. I think you said that back was on the commission, so I want to thank her and members of the Senate Finance Committee for reauthorizing the commission for another 10 years last year. So it's really grateful for that. Let's go to the next slide. We have a list here of our 11 commissioners, all of whom are appointed by the governor. Great group of diverse individuals. Actually, as I was driving here today, I was on the 50 and I got a call from Chair Hagemark, so great Jerry, great group of individuals here. Outstanding commissioners. Thank the governor and the legislature for giving us great folks to serve on. Go to the next slide. Okay, so as the dean said, just under 850 grants totaling $280 million, serving all programs in the jurisdiction. Very first grant that was supported on my watch, because it was 2 or 3 years before I joined the commission, was, I still remember the number, grant number 66, and it was to the Prince George's Health Department to help support the maternal child health prenatal care program. Now, I'm looking at Fran here, she had a difficult at that time. But it was all about investing in prenatal care because of the 3-part strategy to help achieve non-administrative objectives. And so that was the first grant that we awarded. That was in 2010.
So Mark, I'm going to ask you to go up there.
Okay, all right.
Project that. We're still getting used. It's not you, it's me. Okay.
Can I have that
The
microphone
arrows.
on this mound slides? Okay.
The arrow.
All right.
Let's give a shout out online. Can we hear Mark better?
Okay. So all 24 jurisdictions. And the point I also want to make here is we have a very small staff complement. It's like 5-6 full-time people, and we have 213 open grants involving over $200 million. So it's a lot. It's a lot. And so for grantees in the audience, when you send in your reports, we read them. We're subject to the public, the public auditing function. So we take that very seriously to be responsible stewards of the public fisc. Oh, this one here?
This one.
Oh, okay, great. Okay, so as the dean said, the impact of our grants served, what is that? Almost 10% of the state, right? Have been served by commission grants. And it's important, not just the number, but most of these individuals come to the commission with complex health and human service needs. And so we serve an individual and we take pretty seriously the unduplicated individual served. But that individual gets multiple interactions, and we'll talk a little bit about that some more when we get into the Health Equity Resource Act. The legislature, my very first budget hearings, the House Health Appropriations Committee, they said, Mark, they kind of were trying to help me out because they remember I used to work, and they gave me some softballs, and they said, Mark, don't your grants leverage additional funding? And I said, yes. And they said, you should be able to quantify that. So one of the first things we did is we started routinizing, asking grantees to quantify how much they leverage in additional funding. And it's not just, as the expression would go, more government money, getting more government money. The bulk of that 45 million is from private investments. And a sneak preview, I didn't know Dr. Abney was going to be here, but we're going to talk about a special program in Charles County that did just that. And so the other thing, my colleagues in the Department of Budget and Management, they hold us accountable for how many of these grants are sustained at least a year after we send the final check. So we're thrilled that over 3/4 of these grants are sustained after we've provided the initial funding. Okay, I'm going to give 840 grants. Okay, I'm going to give four grants that illustrate the types of success that we're looking to achieve. Right here in Prince George's County, we know that over a long period of time, there's been profound racial disparities that exist with birth outcomes and maternal deaths. Right. Not going to go away anytime soon. So one of the strategies that we've done, working very, very closely with the Department of Health over the years, is to invest in prenatal care programs here in Prince George's County and other areas of the state. So in 2018, we awarded a grant to the Mary Center, a federal qualified health center that serves multiple jurisdictions in the Washington metropolitan area. And we were thrilled that some of the clinical outcomes that it achieved over the years is that it increased access to prenatal care services, which folks in this room know is important to help achieve better birth outcomes. And the percentage of low birth weight babies was less than 5%. I believe, Frank can check my math, but I believe that the statewide was 6%. So right here in Prince George's County, one of the areas that's dearth of primary care, we outperformed the area of the state. That grantee did. Second grant, Movable Feast. And we're going to talk a little bit more about hospital community partnerships. That involves a program that is looking to serve individuals with diabetes. Many of them are homebound, and it served 170 individuals, providing 36,000 medically tailored meals and nutritional counseling. And we were thrilled that 70% of them experienced a reduction in A1C levels. And in doing so, the grantee calculated they achieved just under $1 million in cost savings. Access to food and food insecurity is one of those bedrock social determinants that our commission is focusing on a lot. And many of the health equity resource grants that were just announced a few weeks ago will be doing that. Okay, some of these are a little bit dated, but I wanted to highlight this one. Waystation is a behavioral health provider. They're now part of the Shepherd Pratt system, I believe. But at that time, they were a behavioral health provider in Frederick. And they came to us saying that they wanted to test the Missouri model for comprehensive services for individuals with serious mental illness. And they wanted to pilot the program for a few years as the Department of Health was looking to roll it out statewide. In fact, it's not every day that I get a grant, a letter of support that's signed by both Brian Heppard and Trish Roddy. So I looked at that and went, department's looking at this seriously. And so the commission invested the last $170,000 and the grantee leveraged over $1 million. $170 from the commission, grantee leverage over $1 million from private resources, which includes some of the payers, including Care First. And upon implementation, the department now has over 86 health homes across the state. So that's an example of the commission piloting a specific program that then was rolled out statewide for continued impact. The fourth and final specific grant that I'm going to highlight, I didn't know you were going to be here, Dr. Abney, so it's good. It's good. Sometimes life comes together. Is what's called a mobile integrated health program. And what that is there's a couple of different across the state. There's probably 7 or 8. There might be more. We also have one in Prince George's County and in Queen Anne's County and in Salisbury. The essence of that is if a person calls 911 multiple times to try and unpack the reasons why that person's calling 911 and to help them get the support that they need as they're living in their house, essentially. So never forget it. Dr. Abney was a grant for, I think, 150 grand, and you leveraged 450 grand from others. And over the 2 or 3 years that it was implemented, you see that the statistics speak for themselves. Dr. Abney and her team achieved a 65% reduction in inpatient admissions, 60% reduction in ED visits, and all that was calculated based on our friends from CRISP. And you roll all that up, and it's a savings of over $1 million, almost 1.5 million for a grant for 150. So those are some of our 4 shining examples. There are others I could have done, but I wanted to just give you a flavor to whet your appetite. Okay, I'm going to move now to the first of 2 programs that we've launched over the last 3 years, the Maryland Health Equity Resource Act. It's going to look and sound very similar to an initiative that was underway about 10 or so years ago perhaps Michelle Spencer could elaborate with me as well, but the Maryland Health Enterprise Zone Initiative. So the legislature looked at it and they decided to have a similar program called the Maryland Health Equity Resource Act. And it's essentially a 7-year program that provides $59 million to help reduce health disparities. It was one of several key pieces of legislation that the General Assembly passed a couple of years ago. Another piece of legislation that they passed established the Health Equity Commission. I believe Camille's on that commission as well. We're going to be working very closely with that policymaking entity to help distribute resources. So here you have the 5 statutory objectives of the Act. First, to reduce health disparities. 2, to improve health outcomes. 3, to improve access to primary care. 4th, to promote primary and secondary prevention services. And then 5th, to reduce healthcare costs via hospital admissions and readmissions. Great group of 11 advisory committee members. I previously gave a shout out to Camille and Michelle for serving. Great group of folks, and also Jonathan Dayton. I don't see him yet. He's probably driving. He's got a long drive. Great group of engaged individuals to help us lead this work. So we are we're on the second base, and we're going to year 3 of a 7-year program. First RFP was issued in October of 2021 and generated 9 Pathways to Health Equity grants in February of 2022, and they are implemented over about 2 years. Those 9-year grants are in the process of unwinding, and applicants had to demonstrate that they would achieve those 5 objectives I said earlier, and to demonstrate that they could become a future health equity resource community. Okay, I'll talk about some of those outcomes in a minute. Earlier this summer, the commission issued its second call for proposals, and that generated 12 5-year grants with a 5-year grant period starting this summer going all the way to 2029. And those 12 grants will look at specific social determinants of health, like housing, transportation, employment, and food insecurity. Okay, as I said, nine grants in that initial cohort across the state. We were thrilled that we had programs in most areas of the state, 3 in Baltimore City, 3 in this home jurisdiction, and 3 in rural areas of the state. 5 of those 9 had come from areas that were previously designated the Health Enterprise Zone Initiative. Okay, this is the big aha outcome here. Using the data that our friends from CRISP helped calculate. A special thank you to the legislature for writing them into the bill, providing technical assistance to us. So over 2 years, these 9 grants collectively served, as of March, just over 10,000 people. And you heard me say that they get multiple interactions throughout the course of the 2 years. About just over half of those individuals, the CRISP could do a pre and post analysis of 6 months and then 6 months. So about half of the folks that received services. And if you go through and you unpack this data, you see that you had a reduction of over $2 million in hospital charges. It's a 6% reduction. And you had a reduction, a couple of $100,000 in ED charges, or 9%. And that's just for half of the individuals that have been served. Okay, moving to the next chapter of the Health Enterprise Zone, the Health Equity Resource Community Program. 5 of the grantees that were pathways became Health Equity Resource Community grantees. And you see them up here on the map. But we also are thrilled that there were 7 new programs that were funded, including one that I'll highlight in a moment, Interfaith Works in suburban Maryland, who's never received a grant from the commission before. One of our favorite things at the Community Health Resource Commission is having folks apply for the first time and then getting their grant. Because, back to the title of the presentation, we're all about strengthening the safety net infrastructure. We're not just rewarding grants to sort of check up numbers. The whole point is to provide durable and lasting investment in served communities. Okay, here you have an example of some of the key health disparities that are being addressed. Most of them will be addressing diabetes, and many of them will be applying interventions that address food insecurity as an example. We have several that are addressing maternal child health and several that are addressing behavioral health. Some of the specific social determinants that they are addressing, access to transportation, food insecurity, housing, and employment assistance, among others. Okay, I'm going to highlight two Health Equity Resource Community grantees. The first is a grant to St. Mary's County. Dr. Brewster may have talked about this in prior settings, but she's very passionate and articulate in describing her program. So in her absence, I'll do my best to describe her accomplishments. You have a situation in St. Mary's County where they had a bank. Has she told the story already? Is that she's not so? Okay, so Dr. Brewster found a bank that was not being used by the bank, and she persuaded the bank to donate the property to the St. Mary's Health Department and converted it into a walk-in behavioral health crisis evaluation and treatment services, and also secured a commitment from Greater Baden to provide, and there goes that relationship building, to provide primary care services on site. It was deeply rooted in their health equity task force in St. Mary's County, and she completed her 2 years, applied for a second round funding, and she's launching the second chapter of that grant. Okay, Interfaith Works is a first-time applicant to the Community Health Resource Commission, and they received a 5-year grant to support the Health Equity Resource Community grant. The disparities that they're addressing are mental health and substance use, and they provide an emergency shelter, case management, peer coaching, and medication and treatment services, among several. Okay, that's my blinker. Now we're going to go to the second and final program that I'm going to talk about, the Maryland Consortium on Coordinating Community Supports. I was sitting at my desk just days before we were all dismissed before COVID. So it was like late February, March. I'm at my desk. I get this call. I'm sending over an amendment to the blueprint bill. You have 90 minutes to look at it and don't tell anybody. I'm like, okay. Get through the 10 page. I'm like, wow, this is a lot. So pages 170 through 179 of the blueprint bill, which we all know was vetoed, and then the legislature overrode the veto, has many statutory responsibilities. The principal one of which is to create this statewide framework that provides access to comprehensive, non-stigmatized, holistic behavioral health and wraparound services, all kids K through 12 statewide. We launched that program about 2 years ago. The legislature did us a solid and named former legislator Dave Rudolph as chair, lifelong educator. We're also pleased to work very closely with the National Center on School Mental Health at the University of Maryland School of Medicine, who's providing technical assistance and training. I feel like I say this a lot. Great group of 20 plus appointees. I gave a shout out to Chair Rudolph. Great group of individuals. Really appreciate the very close working relationship that we have with the Maryland Department of Health. I'll give a shout out to Ryan Moran and Aaron McMullen, and also great relationship with the Department of Education and many others at the state level. Great group of engaged individuals, very, very engaged. So I'm not going to read all of these 11 statutory responsibilities, but I think a couple that I would highlight is that the legislature asked us to create, this is the term in the bill, these community support partnerships. And these are entities that will serve as the underpinnings or the administrative component of the statewide framework that the legislature asked us to create. And they will be responsible for coordinating delivery of services in an area, collecting and reporting data prescribed by the state, and serving as a fiduciary agent. Kind of, for those of you that are familiar with the collective impact model, similar to that. Also, the legislature asked the consortium to provide expertise and best practices and training in the delivery of behavioral health and other education interventions. And we're also asked, and that's why Ryan Moran's participation on the consortium is so key, to maximize Medicaid reimbursement, leverage additional revenue from commercial insurers, and also to leverage hospital community benefits as well, which will sound familiar. So we've been meeting for just under 2 years, and we're thrilled that we've gotten out of the gate and we've awarded 129 services grants totaling 111 million, supporting projects in all 24 areas of the state. Significant outreach, all areas of the state. This past summer, it culminated in RFP. We are overwhelmed by the response that we got. And here's a flavor of some of the types of interventions that we're supporting. Prevention and mental health awareness, depression and anxiety, suicide prevention, substance use, trauma-informed care, and then also support for families. Okay, if you step back and you look at all these grants from a 5,000 or 10,000 foot perspective, I said programs in all 24 jurisdictions, They serve, in some cases, pre-K, elementary, middle, and high school age children, and they support interventions at tier 1, which would be through for a whole school as an example, or tier 2, which is more targeted for individuals, and then tier 3, individuals that need more intensive services, such as counseling and psychiatry. Okay, so now that we've all got the grants awarded, we're going to go out and have this summer a public outreach campaign, and we started that in Baltimore County. We had an event about a month ago. As you'll see in the picture there, we were thrilled that Speaker Jones joined us. It was in Woodlawn High School. This is a good microcosm for the different areas of the state. So Baltimore County got 8 grants totaling about $4 million, and they serve elementary, middle, and high school. Woodlawn High School has over 1,000 kids. It's public, and over half of those kids are transient. Imagine that, half are transient. And so there's services that are provided there. Principal Jernigan, who's in the picture, invited us to come and have a nice round table the day before graduation. Imagine that. That's a commitment. Principal has a lot to do for graduation. So we came, showed up. It was great. And so of the 129 grants, right, 129 that were awarded a couple months ago, over half have started providing services across the state, over half. And over 100 will continue services throughout the summer. And we're thrilled that over 300 new staff have been hired by these programs. And we're going to talk about workforce in a minute. Okay, this is my last slide, and we're going to open up for questions, right? So when I spoke with the dean before today, and he helped coach me up about today's presentation, and thank you for that. I wanted to suggest some areas that I thought would stimulate some discussion that I think have already preceded me coming here. So the first would be the sustainability of efforts. You heard me say that we're thrilled the grants that we award are sustained 3/4 of the time after we fund them. So that's pretty good. It's pretty good, but there's a lot more to do. And I think that I'm sure that this group is looking very closely at the AHEAD model. And I think that's going to provide an opportunity to help catalyze further collaboration among public health and population health. And I'm sure that we will talk about that in a moment. The second one, all of these are important, or why would I put them in? But I think the second one is really the most important, because you can't do anything if you don't have relationships. And so one of the things that I found as I got in my car and went to different areas of the state and had meetings with health officers, superintendents, behavioral providers, it's all about the relationships. And in some cases, they're really tight. Like I observed, I'm not just saying it's because she's the co-chair, but in St. Mary's, they have very tight relationships there. In other areas of the state, you show up, they don't know each other. And I know more about what's going on in their jurisdiction than they do. So, it's really important to have those relationships on the system level, but also perhaps more important than that, the interpersonal relationships. They're so important. If you don't have that, what are we doing, right? The third one is data sharing and outcomes. We're really big believers in both quantifiable outcomes like A1C levels or maternal and child health or prenatal care, but then also, the sharing the human impact of these grants, telling stories of those folks that are served by these programs. One of these projects that we did a couple years ago, we had a certain former deputy lend a voice to one of them, the Maryland's Rural Health Stories, right? We had 6 grants across the state that we went out and we interviewed the grantee, who then put a person on camera and said, here's how this grant helped us. That's so important, because if we can't get in the person's shoes that we're trying to serve, what are we doing, right? So that was Maryland's Rural Health Stories. You could ask Jonathan about it, but I think it happened right before he had accepted that position. And then fourth and final is workforce. I've been thinking a lot about workforce, not just because we have several vacancies in our office, which is a big deal, but also the more we go down this behavioral health to children path, the more I see there's just a dearth of behavioral. This is across nurse, like there's a work. It's up, right. It's endemic, if you will. But top of mind for me right now is this behavioral health. Also, I'm a father. If we can stimulate programs that get children interested in becoming practitioners that serve them, then we will start to kind of grow the pipeline. So perhaps you guys have already been talking about that. But I'd like to see our consortium work with others to help get as early as elementary or middle school. We got to get to a place where it's as honorable to be an LCSW as a physician. Like, we got to get to that. That would be my one challenge to send to the group. We got to get to a place where that's what our consortium has helped do. So with that, Dean, I'd be happy to come sit down and take questions as I sit
Why don't
down.
you stay up there because I think the locals will still be, we're gonna get questions from everybody. I want everybody to hear. So thank you, Mark, for that overview and the excellent work you've been doing and for your dedication to public health, right, in Maryland. I think one of the key features is going to be, and we're open up to questions to commissioners first here and then online, so get your questions ready, is ultimately, I'll start with questioning, is what do you want? What would you want out of this commission, the Commission on Public Health? And this doesn't have to be, you know, sort of the concrete items. It could be the relationship items, right? This commission is relatively new. We have a very truncated time period, right? By this winter, we're doing a interim report, which is going to be one of process. By next October is a final report. Realizing that we have an alpha and omega beginning and an end to our existence, what would you want from this commission?
Well, being a former legislative aide, I would say you should focus on what the legislature asked you to do, of course. And so if they said to give us recommendations in this instance, I would start with that. But I think it would be helpful to me if the commission, and I don't suggest this to say that you're not doing this, really looked at how we could try to operationalize and provide funding for further public health and population health partnerships. Some of the things that I'm familiar with are the programs that our commission is involved in, like, for example, the Health Equity Resource Community Act. If you look at the 12 grantees, some of them are led by health departments, such as Dr. Brewster. Some of them are led by hospitals, like GBMC as an example, and some of them are led by community-based organizations like Interfaith. I think we collectively, and the commission can help accelerate this, we have to figure out how we can have more of those interdisciplinary, cross-sectoral partnerships come together and provide the funding and the space and the incentives to do that.
Great, floor is open. Gene, I see you got you're already going. You're ready to go.
I do.
And do speak up here. So
Okay, great. Mark, thank you. Thank you on many occasions when I've seen it, you know, across the state. So I love these four, and I want to take these four through a lens of value-based care and health equity stuff. But there was a couple things I wanted to ask. One is, in some of your slides, you had cost savings, right? And so one of the things that I'm always looking at as we think about health equity, I think of the ROI, but also the ROE, right? Because oftentimes it's, well, what's the return on investment? I love your statement about the human element, because, you know, when you're talking about equity, you're typically talking about populations who have not had trust, and not just the community, it's the doctors, right? I mean, you know, a lot of community-based doctors and have their practices. So I wanted to ask you if you had any information that you could share on how those cost savings, you mentioned Chris does that, how those cost savings are calculated. So that's a good source that so we have that. So that's a request of the second bucket I wanted to just talk about was the AHEAD model and what your thoughts are around that. Congratulations to all the state folks that helped to put that together. We love that. And so I kind of wanted to hear your perspective of how that could best be implemented. And then I'll hold tight. Let me be respectful of other commission members, because I can really dive into these things. I think they're wonderful, and I have lots of ideas.
Well, let's start with those two, and then as we have questions, we can come back to you.
Yep.
Well, so the cost savings, you know, I would want to go by program, because sometimes it's a little bit of methodology, but the most common one is that, like I said, for example, the CRISP analysis of the pathways programs is the pre and post of hospital utilization.
Okay.
But yeah, sure. But, you know, I mean, I'm sure that this group is well familiar with the fact that, you know, I can say, hey, such and such was saved, right? But until this is the holy grail, right? Like, until the hospital starts taking those savings and redirecting them in other ways, it's right. I mean, it's not real until that happens, and that does happen. But that's kind of, you know, that's the holy grail there, right?
understand a little bit how that was happening. Okay, good, thank you. Your thoughts about ahead?
So I'm looking forward to working very closely with my colleagues at the Health Services Cost Review Commission. I know their director very well. I've known him for a while. I know several commissioners there, and of course, my friends at the Department of Health who are leading that work. I think it's just a great opportunity. It's a great opportunity, and I'm looking forward to working with them closely.
Okay, no thoughts right now. It's too early.
I would say it's a little premature.
Great. Other commissioners in the room? Fran?
Oh, thank you. Thank you, Mark. It's great to get a recap of the last 2 decades of whatever it was. Yeah, that's quick. I want to pick up on ahead, but move back to a very specific round of funding that your commission issued to local health departments probably 10 years ago. And it really does relate to what you described as that golden kind of coalition between governmental public health, hospitals, and CBOs or private interests in a region or a community, right? So that was about a decade or so ago. The launch of local health improvement coalitions around the state, which were populated by those sectors that brought together on a local lens the forum by which there would be significant investment in the future in health improvement. That came out of nothing, and the startup funds, the interest to build that infrastructure to staff, minimal staffing, but nevertheless staff that those coalitions around the state came from your commission. So that was, and those commissions are, those coalitions are still lively. So here we are in phase 2, right? We've got, that was a total cost of care model that initiated a lot of that, facilitated it. Now we've got heads. And so I guess I'm going to come to you, Mark, and say, how about some, maybe not startup money, but some bolstering of these, this infrastructure that's in place, but look at it from an equity lens. Look at it from the 2024 lens of what we're going to be doing with the AHEAD model, and really kind of launch local health improvement coalitions 2.0, and use some of your expertise. Maybe the funding could come from HSCRC because Lord knows they got a lot of it, but you have this incredible wealth of experience and relationships around the state with regard to all this experience. So I'm just giving you an idea about some of the coalitions.
Well, thank you for your kind words, Fran. Yeah, I mean, the commission's accomplishments are due in no small part to the General Assembly and our great relationship with the Department of Health. So you've been a big part of that. So, and you know, that for folks that may not be as familiar with the local health improvement coalitions as Fran and I are, they were launched. Everything Fran says is right. So it was about 10 years ago. And the other piece I want to just put out a plug in about that, because I think it may relate to the AHEAD model, as I understand it, is the department, they put together 35 to 40 specific indicators that all 24 jurisdictions were held accountable to. And very easily you could see it was a dashboard, you know, hey, Dorchester and Prince George's, that's the one that comes to mind. Dorchester and Prince George's, they got to expand access to prenatal care services as an example. And so I think if our mindset is that we need to look at the needs of each particular community from a perspective of data, and then the actual residents served, and that's our mentality. And then the local health improvement coalitions could be a key component in helping drive some of the work. And I like basketball, so I'll use the word, you know, they could be the point guard of some of these activities. And so if that could fit in, and here's that word, align with where the department and the Health Services Cost Review Commission envision AHEAD taking us, it's a good opportunity. So, and I would be thrilled to be part of those conversations. Is that about right? So we're
Other commissioners in the room here? Yes.
Hi, thank you for your presentation. One of the things that really stood out in the data that you presented was the significant reduction in admissions and ED visits for the program that was in, I think it was the one in Charles County. And I think one of the things that frustrates, or one of the many things that frustrates me, is that there are a lot of really good programs in our state, throughout our state, but many of the activities are siloed. There was an entire, as well probably know, entire, work group and like task force, and there's still a lot of activity around reducing ED wait times in the state. And I just wondered, were they informed at all by this amazing work that you just shared with us, of which I was not familiar. I don't know who else in the room may not be familiar, but it seems like there's a lot of reinventing the wheel. And I wonder if there's a way to really create a resource that allows us to go into your data sharing outcomes, that allows us to really share best practices. Because a lot of these problems that we're tackling, well, really none of them are new problems. And many of them have been solved to some extent in jurisdictions, but statewide, we continue to struggle.
Yeah, thanks for that. And thank you. Yeah, I mean, one of the things that has occurred to me over the years, the longer I'm here, and I knew it pretty quickly, is that our commission is woefully under communicating the impact of our grants, right? And so, when you launch 2 new programs, you have to kind of prioritize where you spend your efforts. And one of the things that I plan on doing, especially when we get further staffed up here, is to get out and about and help catalyze, is what I'm going to say, catalyze the sharing of best practices, whether it's on a regional basis or jurisdiction by jurisdiction. I failed as I get ready to celebrate 15 years at the commission. I failed to figure out how to clone myself. So you have to kind of prioritize what you do and focus on. But there are a couple of efforts that we've done to help get at a little bit of what you're talking about. One of them is the project, this Maryland Rural Health Stories, where we got out and we had patient vignettes talking about these programs to help stimulate folks to say, oh, okay, well, they're doing that in Charles. Well, maybe I can do that here. And then one of my favorite things to do is to help connect grantee A with grantee B and to kind of help foster those. But I'm a person who likes to do it on an interpersonal level. So, there's only so many hours of the day as an example. But a second initiative that comes to mind is we did this program, not a program, but a project that we did about 5 or 6 forums across the state, where we looked at promising, innovative hospital community partnerships. It's funny how COVID changes our perspective of time and all this. So it was probably 5 or 6 years before COVID. We had a great person that wrote a fabulous report with timeless recommendations that talked about unlocking trapped capital at hospitals and putting them into community investments. And that's out in the public domain. But how many people are going to our website? No, you have to get out, get in your car, go meet with people, and but I thank you for your comment. Yeah.
Great. Commissioners online, if there's questions, Michelle, are you monitoring it all? Okay, Michelle Spencer.
Hi, all. Mark, thank you so much for the presentation and for the reminder of the great work that the commission does. I wanted to get your thoughts, particularly on as we think about workforce. You mentioned the commission's work in providing all of these grants and the collaborative approach and needing to ensure that different communities and grantees are aware of what others are doing. Talk a little bit about, and I think one of your last comments focused on the expertise that is within the commission, but yet that is not elevated in a way where you're able to share. You are almost like the hidden gem of what's available at state level. Talk to us a little bit, please, if you can share about workforce and what grants should or could be available to support the hiring of diverse individuals. And I think the slide that's still on the screen here, it's your last bullet about the importance of workforce, but I'm thinking more around the importance of having a diverse workforce with individuals with varying skills and abilities that can contribute to the work that's being done and the grants that could or should be available. Oftentimes, these grants aren't necessarily targeted towards looking specifically at advancing the community of individuals, but I would love to hear your perspective on that.
Thanks for that, Michelle. Great to hear your voice. Hopefully I'll see you in person soon. And thank you again for your service on the Health Equity Resource Community Advisory Committee. Yep, really appreciate that. So I would say a couple of things. First, I would say when we award the grants and they're highly competitive, we have a pretty transparent process. In our call for proposals, we say, here's the review criteria, and folks know how their proposals will be evaluated. And one of those is gets at, does the proposal or the applicant reflect actual feedback from real people that will be served from these programs? And the longer I'm at this, the more you can pretty quickly suss out, yeah, this one really took the time to listen to residents served and developed interventions that met the people where they are, and other ones that just kind of, as the expression goes, phoned it in, and it's, if you will, astroturf. So that's something that we try to do to prioritize how grants are awarded on a highly committed basis, and largely over the years we can fund about 20% of what's requested to us. So it's highly competitive. The second thing I think that I would suggest, and I think it picks up on the previous question, is I think our commission should do a lot more in getting out and having forums and having, you know, grantees doing this, grantees doing this, grantees doing that, and just having them come together and just have a frank discussion of what's working, what's not working, and sharing best practices in an informal free-flowing discussion. That would be what I have for now. I hope that I got it, what you're getting at, Michelle, but I'm happy to respond to a follow-up question.
I appreciate that, Mark. I think as we are within the workforce committee are thinking about what does our state infrastructure need to look like relative to workforce and individuals that should be a part of that, one of those components is what are the resources that are available, financial and otherwise, that we should be considering? And I think as a grant-making entity, your perspective on what we should be thinking about in shaping this public health workforce, what should that look like? And so I appreciate your thoughts and feedback. Thank you for that.
I'm thinking about one program I'm a little familiar with, not because we funded it, but just because I became connected with it. Folks must know Dave Herman, right? Like he has his mentorship program where he goes into different elementary schools, and he is ultimately trying to encourage folks to get into different healthcare professionals. Like we should have a lot more of those. We should have a lot more of those. I'm a little bit familiar. Is Alan still on the call? Alan from Meredith? Alan, you still on the call?
Still here. Yes.
Yeah. So I know the folks in Meredith very well. You know, if we can have more partnerships where you have medical institutions and other institutions of higher ed, I don't mean to oversell Dr. Perman's, but that's one example that I'm familiar with. You know, I think if our entity in our annual grant making process, Michelle, could help stimulate some of that, maybe connect younger age kids all the way maybe down to elementary school to help them have mentors. Like I said a moment ago, you know, whether it's LCSWs or teachers a little bit tangential from our responsibility. But we need to get folks who are in underserved schools to see that, like, that's what I can become. And then we need to give them the resources, mentorship, scholarships. You know, we need to help them get there. And if our commission can play part of that in helping catalyze it, I would be thrilled to be part of that. Is that kind of getting at your point, Michelle?
Thanks, Mark. That's helpful.
The other commissioners online with questions? Jean, you got one more in you before we
Yeah,
switch
I
to
do. So
presentations?
kind of an alignment with that workforce. When I think about, again, the whole, you know, everything I look at is equity and value-based care. I think about our dualists, trying to work around that, about our peer support counselors, behavioral, you know, that whole, and you're exactly right. I mean, these are very reachable, attainable community that really drive equity. So I think to the extent that we can just try to make sure that those are above livable wage kinds of compensation pieces. I think that that's important. Back to the data sharing. I think that's incredibly, I mean, think about interoperability, what NC is doing. There's just our conversation just with CMI, talking about the reporting requirements that are there. So there's just a lot. I love the sustainability, and you're absolutely right. I mean, relationships got to go beyond paper, right? And so that's so important because sometimes what you see is to write the proposal, you come together, but then the downstream folks that really know, especially when you're thinking about a lot of the learning collaborative, don't know what things will be doing, but it's just to get the contract. So I just wanted to say I really love these areas of future collaboration, and to whatever extent in your grant proposal writing, you can really ensure that this stuff is done, like you mentioned, even getting the member-centric comments and making sure that the qualitative information is just as important as that quantitative when you're trying to drive that forward.
Great. Mark, thank you so much for your presentation. And you are one of these people who have served the state so well with your passion, with your dedication, and you will continue to serve, and we will reach out to you. We already warned Mark that he will be part of our key informant interview process when we get to the assessment. So, that opens up the opportunity for us to have that further interaction. But also, I go back to my question initially. Let's make sure that we're coexisting, and not only coexisting, but cooperating with our commissions, right? And making sure that we are serving you as necessary and that you are helping us. So thank you.
You're welcome.
Great. Our next speaker, and then we'll take our break afterwards. So roughly 3:45 or so, and then we'll take a little break. There are, however, still snacks here, some waters, various things. So commissioners and guests, if you so desire, because of the benevolence of our local health department, we are thrilled to be greeted in such a great fashion. Jonathan Dayton, I assume you are on.
I am, Mr. Chair. Thank you.
Okay, great. Thank you so much, because I'm ready to praise you even before you start speaking. Jonathan Dayton, he's a native of Western Maryland, lives out there with his wife, Addison. He is the chief executive or executive director of the Maryland Rural Health Association. This is now another key partnership for us, because although we may live in a certain facet in Maryland and view Maryland as being much like us, we know the truth. The truth of Maryland, it is very diverse. For a relatively small state in terms of its size, right? We span the globe from, rural to suburban to urban to inner city to rich, to poor, to every single race, color, and creed out there. That's the beauty of our state. But certainly one thing that we must do as a commission is really look at specifically that rural population that oftentimes comes with its own challenges and opportunities when it comes to the public health model. He has an extensive background in healthcare delivery systems, value-based care models, rural community healthcare development, program development and administration, rural underserved community enhancement, and nonprofit marketing. He had previous experience with the Maryland Rural Health Association, serving on the conference committee for several years before taking on the job as executive director. Before his time at MRHA, Jonathan serves as the community relations and population health manager for Mountain Laurel Medical Center, which is a federal qualified health center in Oakland, Maryland, and has also served on the Mountain Laurel Medical Center board of directors and worked at UPMC Western Maryland in physical therapy. He serves its community in various roles, including as a volunteer firefighter in EMT with the Potomac Volunteer Fire Company and Baltimore Pike Volunteer Fire Company. He brings legislative experience and currently served 2 terms on the Maryland Youth Advisory Council. In addition to this extensive volunteer work, he serves on Maryland Governor's Emergency Management Advisory Council, the State Advisory Council on Health and Wellness, the Health Equity Resource Community Advisory Committee, and the board member at large of the Maryland Public Health Association. He earned his associate degree in fire science from Columbia Southern University, a Bachelor of Science in Psychology and Pre-Medicine from Frostburg State, and an MS in Management and Leadership from Western Governors University. He's currently attending Capital University, pursuing what? His DRPH, the Doctorate in Public Health. He's a Maryland licensed emergency medical technician. Again, a warm welcome to our guest who's going to be with us online, Jonathan Baker.
Thank you, Mr. Chair, for the warm introduction. I will keep my camera off while I'm presenting, and I will turn it on when I have a discussion with you after the presentation. It's good to see a lot of colleagues that I've worked with over the past several years, again, via virtually or in person in the room on the camera. Today's presentation will be just a very brief overview of rural health. I really wanted, again, to make this a conversational piece and look forward to the engagement after the presentation, but to give you a little bit of a perspective of rural healthcare, the landscape in Maryland specifically. And I have a couple of items I'm going to talk about that kind of relate back to Mr. Lochner's presentation that he just gave. So I look forward to having the next several minutes to engage with you. So the next slide, please. So if you weren't aware, there are many definitions of rural Maryland and rural counties across the country. The federal government has probably 10 to 15 different definitions. However, Maryland designates 18 of the 24 jurisdictions as rural. And what I always love to say is Maryland is a rural state by geography. So 75% of Maryland is considered rural, except obviously some of the large urban areas, Montgomery, Howard, Prince George's, etc. That encompasses about 1.8 million Marylanders based on the last census, which is about 25% of the Maryland population. Next slide, please. So the Maryland Rural Health Association. So the Rural Health Association has been around now for over 20 years. It doesn't feel like it's been around that long. It was formed in 1995 as a result of a conference hosted by the State Office of Rural Health, which I will briefly talk about here in a moment. MRHA's background is very vast, and there are a variety of things that MRHA focuses on. I like to say that MRHA really focuses on three main areas. The first area that MRHA focuses on is education, a big proponent of best practice sharing, which we've talked about in the previous presentation. Obviously, we host the largest rural health conference within the state of Maryland. We do podcasts, webinars for all of our membership as well. The second big piece of MRHA is really focused on advocacy and education, both at a state level, obviously, very active and engaged during the Maryland General Assembly session, but also very active and engaged in our federal government as well. We're very present with our partners in Washington, D.C. on a very regular basis, advocating obviously for policies to improve the health and well-being of rural Marylanders. And that third piece, since we are a membership-based organization, having a fluctuation between 50 and 80 members at any given time, and over 200 individual members representing about 20,000 plus employees at any given time. We are really engaged in technical assistance, obviously assisting our membership with marketing, grant writing, grant assistance, etc. MRHA is, again, a membership-based organization, so I should point out that we represent a variety of different stakeholders across the state. That includes local health departments, that includes local hospital systems, obviously community-based organizations like the AHEX across the state. And then we also have some partnerships that we built with organizations like the Maryland Farm Bureau, the Maryland Public Health Association, the National Rural Health Association, NAMI Maryland, etc. Next slide, please. So like I mentioned, 25% of Marylanders live in rural communities. I know I often say that, the best parts of Maryland are those rural areas, the mountains. There's lots of outdoor recreation, but with outdoor recreation, with the mountains comes, again, a very unique set of healthcare challenges that we're going to talk about here in just a moment. And again, that includes obviously we just chatted about, the lack of healthcare providers or difficulty for providers. Transportation is a huge barrier within our communities. Living in Cumberland, Maryland, which is in Allegheny County, when we talk about healthcare solutions, one of the solutions that I heard about not too long ago from a group of individuals was we should bring in Uber and Lyft programs to rural Maryland. And I said that would be great. The only challenge to that, right, is that there are only so many of those drivers available in small rural areas. And obviously, those companies obviously need to have a financial impact in order for them to move into certain areas. And again, technology barriers. We are big, huge proponents of telehealth and telehealth services across rural communities. However, broadband still seems to be very much an issue in rural areas. Here, specifically in Allegheny County, individuals live 45, even an hour within their own county from healthcare services. And when they live in such rural, isolated areas, broadband is a very significant challenge. And so where telehealth could be a great tool and resource for these individuals, again, they don't have that ability or capability because of lack of broadband. However, in recent years, obviously, we've talked about the expansion of audio-only versions of telehealth. So there are some ways that we can obviously get these individuals the care that they need. Next slide, please. So I did mention the State Office of Rural Health, or SOAR. So within the Maryland Department of Health, there is a State Office of Rural Health. Director Sarah Seitz leads that office and initiatives. I won't go down and read absolutely everything for you bullet by bullet, but you can see that they're really a focused area on all things regarding rural health issues. Obviously, they're a big proponent of research and innovation. Sarah's office also works a lot on workforce issues across the state and healthcare. Additionally, I think it's important to note that, SOAR also is kind of the lead on the statewide telehealth interest group. Over the years, that statewide telehealth interest group has kind of evolved by who is leading that particular effort, but it does kind of sit with SOAR. Again, telehealth being a great resource for rural communities. Next slide, please. With SOAR, we did a great partner initiative along with the Robert Wood Johnson Foundation and the Rural Maryland Council back in 2018. And so I want to briefly give you some quick results from 2018, but I also want to kind of highlight 2023 and some of the planning we did in those stages as well. So the 2023 version, which I get asked about quite frequently, is not released yet. It is still sitting with SOAR, but we were contracted to do some of the work regarding the 2023 Rural Health Plan. Although I can't share absolutely everything that took place in that particular version of plan, I will tell you that, what Mark Luckner had reported about reaching all areas across the state is something that we did not only in 2023, but also in 2018. So the gathering of data for the Rural Health Plan, again, took place via stakeholder meetings across every region of rural Maryland. So in order to solicit data, it was done via more than just a typical survey. We went to specific areas in rural Maryland and held stakeholder-focused interest groups to put together our plan. Our plan had about 6 major areas that they found that needed to be focused on. And that number one is access to care. Again, reducing barriers and gaps across rural Maryland to include particular areas of concern to them in 2018 included, again, general practitioners or primary care, specialists, behavioral health providers, and oral health providers. Obviously, again, in combination with urgent care in emergency facilities. And I always tell the story, about my neighboring county of Garrett. When we look at specialists and specialty care, psychiatrists were far and few between for Garrett County. And so for Garrett County residents, obviously to seek mental health and behavioral health care, they were either booked out months to see the one sole provider in Garrett County, or obviously they were traveling hours among hours to get to specialist care. And for folks that live in Garrett County, the next closest specialty facility is actually in West Virginia, in Morgantown. So they were either driving an hour west to seek specialist care, or they were driving 2 hours to Pittsburgh or 2 hours to Baltimore. And for individuals living in urban areas that are very close to these urban centered resources, it's a quick public transit ride to your specialist. Obviously, you can get back to work typically if you have a morning appointment. However, for access to care for folks living in these rural areas, it is a full lost day of wage to go see a specialist provider. And for many folks that live in rural communities, a full lost day of wage is not something that they could afford, especially for our farming community, especially for our trades workers. Again, affordability of taking days off of work to seek that care is, again, very challenging. Additional things that we had discussed in 2018 include sustainable funding mechanisms for healthcare services, again, permanent funds of streaming, obviously looking at some reimbursement systems to improve that healthcare, including emergency medical services, again, a high need for rural areas, and care coordination. Next slide, please. The remaining three things that were found in 2018 included chronic disease prevention and management, reducing, obviously, the incidence of new chronic diseases, and increasing the ability for people to manage those particular conditions. Health literacy and health insurance literacy was a huge particular barrier in 2018 and still continues to be a huge barrier in 2024 and 2023. Health literacy, education, breaking down barriers for folks to navigate resources is something that we've been huge advocates for over the past several years. And additionally, outreach and education, working with services, both healthcare services and community-based services to increase public outreach is something that we've lacked over the years. We have definitely improved. And I say improved in the way of, obviously, one of the assets to healthcare this particular wave is community health workers. Community health workers, again, have been a huge asset to increasing that outreach and education. Looking at ways to particularly fund CHWs in a more permanent stream is something that we obviously need to work on as a state, work on as a country as well. But community health workers has definitely helped to bridge that gap. And when I talk about community health workers, I always need to mention and I always want to mention the word trust. So in rural communities, trust is a huge factor. So during COVID, I worked very closely with our health department in Garrett County, having an EMS background that was able to go help with the testing and the administration of vaccinations. In the first, several months of the testing, again, it was very busy, basically those first, several months, and continued to be fairly busy throughout the emergency. Then when we went to the vaccination portion, it was very busy again for the first few months of the rollout of the vaccination, but then dipped off significantly. And we asked ourselves, why is only 50% of the population taking advantage of vaccinations when it's readily available? And the number one thing we heard from the community was trust. We don't trust healthcare. We don't trust, obviously, science was the big word there. We don't trust, individuals in general. And so why would we go do that? And so finding ways to bridge the trust gap in rural communities, and those challenges still very much exist within Maryland. Next slide, please. So I find it ironic that Mr. Luckner had, and Mark's a good friend, had mentioned the video that they had produced in coordination with MRHA about 4 years ago. I did have that to play, so if we could play it, it's very short, it's only a few minutes long, and we will finish up the presentation if we could.
I don't know if I can play that, but I'll try.
The link on the slide could be opened in another window if that's possible. If not, that's also okay. We most certainly could share the link out. Commission.
Yeah, I think we should share the link out right now. I don't think that I can pull it up. It's
That's okay.
embedded in the slide.
No worries whatsoever. The story we most certainly can share out to you so you can watch it. But again, Mark had mentioned that we did produce 4 different videos in coordination with the Community Health Resources Commission. And again, I want to stress the importance of looking, at particular solutions that are going to impact all areas of the state, including those that live in rural communities. And I guess, that's kind of the theme of, my presentation today is, again, to make sure that you are, taking a very close look at particular challenges that exist within rural communities, again, because they, directly and greatly differ from a lot of the challenges that are taking place in other areas of the state. Next slide, please. And again, I wanted to briefly mention the Rural Health Plan 2023. Obviously, there's not a whole lot for me to share. However, we were contracted to do the work. A draft plan has been produced, and obviously, as soon as it is available, we will most certainly, again, disseminate that information with source assistance in the State Office of Department of Health. I will also say that the 2018 information, I did share that with part of the people that are working with the commission. Obviously, we can share that out with the commission so that you can have the public access of the 2018 data. Next slide, please. We also talked about this in our last conversation just a moment ago with Mark, was public health challenges and looking at provider challenges that had been discussed by some of the commission members. Obviously that continues to be a great challenge for a lot of rural areas. There are a few, I again won't say that there's none, there are a few different incentive programs for public health providers, especially those providers of primary care and specialty care for rural communities. And obviously we're big advocates and proponents of Meritus's osteopathic school. We think that will be a great draw for students, but also a huge asset for rural communities across Maryland. However, education, again, systems tend to be urban centric. Rural health provider fellowship programs and programs of that nature are, are far and few between. Obviously, there's just very limited rural health focused programs, even at community colleges within rural areas. Obviously, rural areas and the training, again, is much different than urban areas. So when providers are seeking their training for medical school, obviously, the rural health centered care is a lot different than urban centered care. I talked to some of my provider colleagues, and they say that they can be a OBGYN one day, and next day they could be a neurologist, and next day they could be a general surgeon, because obviously they're seeing such robust clientele, and clientele that not only don't necessarily want to go see their primary care provider, but definitely have challenges getting, again, to see specialty providers. And obviously the demographics of rural areas are much different. Again, higher tendencies of elderly residents, again, in rural areas that receive and require a much different type of care. Next slide, please. And again, economics again is a huge factor. Obviously, salaries tend to be higher, benefits tend to be better, and working conditions, again, tend to be better in more urban focused areas, obviously within the cities. There are, again, a lot of jobs open, but again, salaries and benefits may not be comparable for those urban areas compared to rural areas across the state. Training, again, is more expensive typically for health professions that want to practice in rural areas, and less affordable to students. And again, obviously the jobs can be very challenging for spouses. I also chair the Midshore Local Health Improvement Coalition Provider Recruitment and Retention Work Group. And one of the things we hear from the providers that are a part of that work group is spouses, again, being a particular challenge for providers. We can recruit in a specialty provider for Pittsburgh or from New York to come down, but then the spouse, again, has challenges because they want a certain way of living, whether that would be obviously school, shopping, restaurants, things of that nature. And again, the rural way of living is much different, obviously, than urban way of living, especially for folks that have grown up in urban areas and, again, did their training in urban areas as well. Next slide, please. I won't touch on this too much, other than we already have talked a little bit about it. Again, there's public health literacy challenges, again, being issues for folks. Currently, MRHA are looking at ways to kind of address that across the board in a lot of our areas. There are significant challenges that still exist. Obviously, one of those is cultural and language barriers. Again, I mentioned the word trust earlier being a huge issue in rural communities, and obviously, financial constraints with actually going and taking time off to see your public health professionals or physicians, obviously, is a challenge, and the digital divide's even a challenge. I always tell the story of when I was at the F3HC prior to coming to the Rural Health Association, and that was during COVID. We had stood up a telehealth system from the ground up to offer telehealth appointments to our primary care patients, and we heard time and time again, I don't want to see you via video. I'm coming in regardless of COVID, right? And that's, was kind of alarming, but then we kind of sat back and wondered why that was. And it was because of the digital divide and the elderly population, being more comfortable with seeing someone face to face, but also additionally, they didn't understand how to use technology. When you're 70 years old or 75, 80 years old, and you've never used an iPad or used a webcam before, again, those are very real challenges that, again, require very unique solutions to, especially for rural communities across the state of Maryland. Next slide, please. Transportation, if I was going to point to one particular area that I think that I hear the most challenges with, and that is, again, public transit. I heard earlier that, and I mentioned earlier about Lyft and particular ride shares coming to areas, and again, the lack of those drivers in certain areas. But 8.2% of Marylanders, again, have no vehicles and struggle with transportation. Obviously, that's compounded within the rural communities. And public transit in rural areas is very non-existent. So when you look at the whole picture of public health care, one of the solutions I hear is, well, you have public transit, you could leverage public transit to get folks to and from necessary appointments. However, that doesn't exist in rural counties, especially, looking particularly at Allegheny County, again, my home county. We do have a public transit system. However, it goes from one route. It goes to and from a few different shops, and basically that's it. And however, it does not go to the healthcare providers per se. It does not go to the specialty providers. And if it happens to go per se to the hospital system and drops you off, it might not be back around for 2 or 3 more hours. And again, that poses significant challenges when it comes to getting individuals to their care. And so while they may be able to access public transit, again, it's very tricky situations occur because, again, they're taking significant time off work. And again, for someone that's retired, they may be able to balance and manage that. But for, the working class individuals, especially, 30 to 55, obviously that becomes, quite an issue. Next slide, please. I did just briefly want to mention before we open it up for some questions, just new CDC Office of Rural Health. So if you weren't aware, the Center for Disease Control and Prevention obviously had stood up a brand new Office of Rural Health focused on rural challenges across the country. They were funded at about $5 million, and we are currently advocating and seeking some additional funding from the federal government to continue to fund them through several more years. We hope that they're around forever, but having an office within CDC that's focused directly on rural health is a huge asset for not only Maryland, but for rural people that live in rural areas across the country. Next slide, please. And I wanted to share with you at the end some resources. Obviously, you're probably very familiar with many of these resources. However, I did want to share with you a few so that way you are aware. I did share with, again, the colleagues that were setting up today's call, some other reports. Happy to share some additional resources that I have to the commission to inform you of some of the other challenges and potential resources that are available to you. I want to thank the commission for your time to allow me to present, and I look forward to answering some questions.
Jonathan, I believe we have the video. If you want to show that, I think we can present that now.
Please, if you have it pulled up, I would welcome it. It's only 3 or 4 minutes long. I think it would be very helpful to see.
Okay, just give us a second.
Does there happen to be volume with the video?
It's not muted.
See right there.
Was that not working? The sound?
No.
Okay, let me double check one more thing.
Give us just another
Shane is
30
presenting.
seconds if we can do it. If not,
Shane is
we'll try to
presenting.
send a link out to everybody. For everybody in the room here as well.
This video, special collaboration between the Commission and the Maryland Rural Health Association, highlights a promising telehealth program that is marshaling state resources and helping bridge the gap in Garrett County to address the opioid epidemic in this rural area of the state.
I have been a drug addict for 20 years. Methamphetamine is a very mental drug. When I would get high, every time I would just be like downing myself. Like, what are you doing? Oh my God, this is ridiculous. You've lost so much. You can only keep going on like this for so much longer. You're going to go to prison. You're going to lose everything all over again, which I didn't have a whole lot of nothing, but I had my freedom, and that's what I knew. So my husband, I wanted to be clean, but he was very abusive, and he was there and cooking it. If it's in your face, it's hard. I had to move out. I was, living on the streets, whatever I had to do, steal for my clothes, my food. I didn't do the things that normal people do. People here, they want you to know they care, and if you want the help, they'll care for you to get the help. When their treatment plan is made, we include every area of their life for the medication to be a tool rather than the whole recovery. What Suboxone does for them is it keeps them healthy. Once I started taking it regularly, like I'm supposed to, on time, every day, I quit getting cravings. I quit even wanting drugs. I got a job and I just had a routine again. I was learning how to live in life. They're seeing 4 counselors a week here in Garrett County. We just don't have very many doctors. Dr. Weintraub is in Baltimore, and it looks like he's right there with them.
I talk about recovery.
Yeah.
That's pretty big.
Even though it's through telepsych, that comes across for them. I'm struggling with anything as far as drug related or in my life. They're there to listen. It's been a big part of my recovery. This program has actually helped the community to start to see that there is success. They have a chance with us. Quite a few employers in the area were willing to hire them, when before they just wouldn't even look at them. If I wouldn't have got my life together, then I wouldn't be helping others. We want to help other people that are addicts. That's the reason why this program is important and it should be supported. It saved my life.
We view the Maryland Community Health Resources Commission as a vital partner.
The statutory mission of our commission to expand access in underserved communities and to serve vulnerable populations is more important now than ever.
Thank you, Shane, for sharing that. And I will close by saying that, Mark had done a great job highlighting, again, those videos. But the reason why I had actually included it in my presentation was, and I heard this from one of the commissioners that you mentioned, silos and replication of services. One thing that I've been a huge advocate for is, we do a lot of great things in Maryland, tons of wonderful programs within Maryland. And a lot of those are replicable, obviously, but obviously I think some areas do work in silos. We try our hardest at our conference and other events that we host to, share those best practices so that other communities across the state can replicate those great programs in their own jurisdictions. And so, again, that's the reason why I felt that that video was very necessary. And again, just highlighting one of the former commissioners' comments during Mark's presentation about silos and best practices. So with that, I will yield back to the chair and happy to answer any questions.
Great. Thank you so much, Jonathan. Thank you for that interesting and very informative presentation. I'll start off the questioning. It's really looking at, your relationship with other rural health associations across the nation and the National Rural Health Association. Have you found or are you able to share any best practices from others out there who are struggling with the same issues, and specifically in the area of recruitment, right? Of whether it's healthcare providers, whether it's public health personnel in rural settings, anything that you've seen that we should be considering here, right, for the state of Maryland?
That's a great question. And ironically enough, on Monday, I leave to go to Portland, and I'm going to meet with every single state rural health association executive director all in one place. We meet yearly. And so Monday, actually, we get together and, talk about these exact same challenges. Immediate things to share with you. I don't have a whole lot, but I will tell you one of the things I'm excited for next week is it's more related around policy. So at the National Rural Health Association, I actually just met with one of their colleagues last week and talked to them about things that Maryland's doing from a policy standpoint, like standing up a commission like this to look at public health and some other particular initiatives that Maryland's done. They're putting together a guide of other states' policy wins, per se, things that are easily replicable policy-wise from Vermont to Maryland, or from Missouri did this program. It could be, carried over to Maryland. So when I return next week, I should have a very robust guide of some things that we could do and consider, obviously, in Maryland, based on some best practices from other policy groups across the entire country. So I have more on that next week to answer your question.
Thank you. And one other follow-up question, it's sort of in a different scheme, but I was intrigued with your description, which oftentimes is the description, is, for example, the population, individuals from the rural community seeking care, with urban areas, going to Morgantown, going to Pittsburgh, as you mentioned, from Western Maryland. Do you ever see the flow in an opposite direction, i.e., individuals from urban or suburban areas going into rural areas to seek, for example, the standard issue of healthcare, for example, would be one of the wait times or finding a primary care physician in an urban setting. Have you ever looked at that flow, and does that have an impact on care?
So yes and no. So I'll give you the short answer is that when it comes to healthcare, I often don't see urban individuals seeking care in rural areas. However, I do see urban individuals moving to rural areas, not specifically for healthcare related issues. From the ER wait time standpoint, one of the things that we do see is that a lot of our rural constituents, instead of going to their most local hospital system, they may travel a half an hour out of their way to go to a smaller hospital because they know that the wait times there are going to be usually significantly less than going right down the road to the hospital in their backyard. So that sometimes are things that we do see from a rural health perspective. Sorry, I didn't hear that comment or question.
In the room here so far. Okay, questions from commissioners on online? Yes, to the left.
First off, Jonathan, always good to see you. In thinking about this, right, like I was glad that you mentioned the FQ perspective. I still think of myself as a lapsed FQ person, no matter where I am. I think one of the challenges I think about, right, is I'm not a technology first as a solution kind of person, but I think we've struggled with this issue of access in the rural space for a really long time, right? And so my question to you really is like, and I, I was intrigued to hear. I'm intrigued to hear about your what you come back with from Portland. But how do we mesh technology and presence, right? So thinking about, right, mobile services or something that we've tried. How do you get the density of that? Very hard to do that once you get anything beyond primary care services, right? Like you just don't have the density of that. How do you mesh that? Like how do you have some hybrid models where you have some clinical staff maybe with some tele services, right? Like we've got to do more to kind of use technology well, right? Not to replace the human component, but to augment it so that we're delivering services. And I say that in the care context, but I also think it's important from the preventive context as well, right? That's really I always think about how do we need less healthcare so that we don't have as many access issues, right? How do we just keep people healthy? So I just throw that out. I don't, I know that's kind of a pie in the sky-ish, but I want to get your thoughts.
Yeah, and I appreciate the question. And so, finding a way to strike the right balance, I think, is a challenge when it comes to technology, especially for rural individuals. So from the FQHC perspective, again, one of the programs that I was tasked with when I was there was we had never had any community health workers, nor did we have any mobile services. And so my task was go spec out a mobile unit, build it from the ground up, and then hire some staff to go do outreach, which we did. And we were very successful in our first year of doing that. We reached 3,000 individuals in 1 year. But the point that I'm making there was two things. One, we did it in a way that was different. There was no clinical services initially. It was strictly outreach. We considered ourselves a mobile library on wheels. It took a screener. Based on the screener, you were able, and then we referred you to XYZ resources because there were already, again, great resources in the community. Why should we duplicate that? Let's refer you. Then when the conversation became to sustainability, we're not making anything off this. We're not billing for any services, right? So what is and how is this sustainable? And it came down to, obviously, we can put a physician or a nurse practitioner and go out to communities, but we're only going to see a very small handful of individuals. And I think this is a much larger conversation, but one thing that I often hear is, from the grant perspective, you need to reach 5,000 unduplicated individuals within a 5-year period to, indicate success. But in rural areas, that's not possible because, the folks that need the care the most are the ones that are going to take a team of people 2 hours to go get to. So you may only see 3 people from a mobile healthcare perspective. And again, that's not sustainable because you're not making any money. You're probably in that case losing money. So how do we, again, strike that right balance of finding ways to reach people where they're at using technology and investing monies that are going to be advantageous for the state? Again, that's not an answer to your question, but that's just other questions that need to be posed during this conversation.
Other questions online from commissioners?
I have a comment, a few comments. My name is Rosalie Bright, and I'm a retired epidemiologist. So I've heard over the years that the VA has been pioneering telehealth programs, partly to serve the elderly rural constituents and partly to do research on the best way to provide them care. So they use a combination of iPads and telemonitors that are set up in the residence housing, and they train the patients on how to use the iPad when they're at the VA facility and then send them home with them. And so you might want to look up or contact someone in that program to get more of the practical details about how well that's working. And Norway has a similar situation with a couple of major cities and then a huge geographic expanse of rural areas in difficult to reach terrain. And they've been working on trying to have more extensive psychology services throughout the country. And I know they've tried a variety of things with having guest workers from other countries come and provide psychiatric and psychology care, trying to incentivize living in those places. They have to deal with these clinicians getting seasonal affective disorder themselves. And I recently heard about a program where an area will try to fly someone in regularly for, say, 2 days a week to provide care. So I know, obviously the struggle is global import, but I do think it's probably important to be super flexible and creative in thinking about, well, do we try to get someone out here permanently, a specialist out here permanently, or do we try to get them to commit to 1 day a week and we rotate the physical clinic among different specialists throughout the week, and the specialists come out for 1 day, or they go to a different rural area each day, or what? I don't know. It seems like a daunting challenge, but there are countries trying to deal with it. I know in Australia, there are physicians flying around in their little Cub airplanes to reach areas to provide care. It seems like a lot of this can't really rely on private payers to fund. It seems to me there needs to be a public effort to serve people in the rural communities. That's all.
Mayor Jonathan.
Cynthia has her hand up.
I know, but Jonathan seems to be. Are you frozen? Are you okay?
No, I'm good. I was waiting to see if you were going to call on Cynthia, but to
Okay, no. Any comment on those comments?
Just to Rosalie's point, I do think, all her comments were, valid. I will say that we are in contact with the VA on a couple different initiatives. And one of the things that sparked in my head when, Rosalie, you were talking was there are some programs with public library systems putting in telehealth booths, basically a space where individuals that don't have broadband access but have easy access to the library system can go in and obtain telehealth services in that particular setting. Again, having a private booth and room that's soundproof with quick broadband access and obviously a web camera capability. And so there are other conversations that we're having with folks that are, innovative approaches to, again, these challenges. That's my only comment.
Okay, and Cynthia Bauer is one of our working group members. Cynthia.
Thanks, Boris. So, hi, Jonathan. I'm on the Communications Public Engagement Work Group. And one of my questions, because I know you know about the work of the Office of Statewide Broadband and what Cooperative Extension is doing with the entire digital literacy and, the training, the handing out devices. So I think maybe for the commission's benefit and also just thinking about recommendations, you know, I was curious that you didn't really reference that and all the funding that Maryland is putting into broadband and training and getting devices to people. So is there something going on that's inadequate from a telehealth perspective? Is there something more the commission should be thinking about in terms of what the Office of Statewide Broadband could do? Is it a matter of more money that's going into those programs? You know, sort of what can this commission do that can really enhance the millions of dollars the state's already investing in really building out this infrastructure for telehealth, but it still seems to be inadequate for the need that you described?
Yeah, so I never wanted to undercut or discount the work that the office is doing. I only had so much time to put into the presentation of all the different programs that are going on and that are available. I will say a couple of comments, and one again wasn't an issue. We in Allegheny County had received funding to get Chromebooks into the hands of individuals that needed technology, right? And we were very thankful for that. But one of the things that I had noticed was that they were giving out free technology to folks, and some of those individuals that obviously qualified due to their income levels didn't have broadband at home. So we're giving some technology resources to individuals, and again, they're still going home with basically a piece of technology that they would have to go somewhere public to utilize. And these individuals, you know, most could go somewhere to utilize public, you know, accessible Wi-Fi, library system, coffee shop, restaurant, etc. However, again, we go back to the cycle of issues, and the next issue is transportation. So if these folks qualify to get a free Chromebook, there's a very high likelihood that transportation is an issue. And if transportation is an issue and they don't have broadband, then how are they going to get to a particular source of public accessible Wi-Fi? So that's just a comment there. But to your point, there are great initiatives going on across the state when it comes to broadband expansion. The federal government had a program that was in place, and we had done some work on the Midshore to promote that particular program as well. So there are a lot of great things going on. I think the part of, again, you know, what needs to be improved, I think, across the board is just communication about all of the existing resources and new resources that are available to individuals, because I think that from just a personal standpoint, so much goes on daily within the healthcare space that it's sometimes hard also to keep up with what's going on, what's available for individuals. And so finding a way to more centralize that, I think, across the board, I think would be, you know, obviously very helpful for myself, but for especially the constituents that need access to those resources.
Yeah, can I just make one follow-up comment? Because I think that, you know, there's a couple of things suggested there is like, yeah, obviously it's pretty foolish if they were giving out any kind of devices without any connectivity. But these are programs, that's what I'm saying, is we have the state that supposedly, and there's somebody who's in charge of digital equity actually within that office. So if there are, for example, they don't fully appreciate what digital equity means in the healthcare space, that's something the commission could consider. Or if the broadband rollout isn't fast enough, right? Or there's just not enough, the need is greater than what the state has funded. Those are all things that I think if the, you know, if telehealth is identified as a weakness for, you know, making progress in rural health, I think that's what I'm suggesting the commission could think about is if the state's investing in these other places, how could the commission either reinforce or comment on or support an expansion of things that other agencies can do so there is more of that collaboration and partnership.
Great. Thank you, Cynthia. And thank you, Jonathan, for a great presentation and a great discussion. Obviously, again, our key role of this commission is to make sure that we are interacting with all the elements that are involved, both in healthcare, population health, and in public health throughout the state. So thank you for being one of our partners, and we will reach out as we need more information and want that cooperation with you as well. So thank you so much for your time here today. We will now take a slightly shorter break, a 10-minute break here until 4:05. That's 16:05 for those of you on the 24-hour clock. And so once again, there's refreshments here. For those of you online, we'll re-engage at 4:05 p.m. and continue our meeting at that stage. But thank you to both our speakers. I think this was really a worthwhile first session for us to expand our horizons. So thank you all. See you at 4:05. You good, Michelle? Good, should have been? Yes. I'm testing the virtual world. Can someone hear me? Give me a signal. Okay, great. So we're going to begin the latter part, the last 1/3 of our meeting. We've decided to give the work groups a break this meeting, so there's going to be no working group reports unless somebody out there in the working groups has something to say under other announcements. We encourage the sharing of information, but certainly nothing mandatory this time. We will, however, set aside time at this point both for commission updates as well as other information that needs to be shared with the commission and with the attendees here today. But I do want to start off a little bit off script. And Nilesh, are you on?
I am, yes.
Nilesh, you out there?
Yeah, I'm here.
See there? Yes. Yes.
I don't
Nilesh,
think
give
you
me
can
a sense. Okay, there he is. Okay. I'm just gonna, I asked Nilesh to comment on something that I think we need. You know, we're not only the bearer of good news here occasionally and aspirations, but we are occasionally have to tackle the reality of the life around us. And as we were driving in, and I must have missed this news story earlier today, but there was a news story today on that came from, at least the source I'm looking at is from National Public Radio talking about how Governor Moore is trying to balance the budget in the state of Maryland. We all knew as we were starting out this commission that we were not entering the best of economic times for the state of Maryland. But we did receive some news about the potential or the cutting of $26 million in Maryland Department of Health funding.
What was that number?
26 million. That and you know, and it's not to put pressure on Nilesh. Nilesh was not the decision maker on this, but I did brief him earlier and just wanted to get, you know, what do you know, Nilesh, and what do we as a commission need to know from the announcements that came out?
Sure. So, as
Can you hear Nilesh? You're on mute.
How's that? Is that better?
We still have you on mute.
No, we can.
No, we can hear him.
We can hear him.
Virtual can hear.
I wonder.
Can you
I wonder if it's the room.
Can others hear him on. We can hear him. We can't hear him here. Okay, so 1 second, Nilesh.
And Boris, we can hear you too.
I don't think so. Our microphone is on.
Is that better?
Okay, they can hear online. Nilesh, say something again.
I will give it another go.
Okay.
Okay.
Okay, give us 1 minute here just to figure out what went wrong in our room. I thought for a second, Governor Moore's office got in and somehow stopped the flow of information to us. I'm just joking on that. Anytime you say a joke is official commission duty, you have to always say it's a joke. You have to lay it on its side. So notice I put in my reference there.
Let me stop presenting for a second, okay?
Okay, Nilesh, try it again one more time.
All right. How are we now?
Okay, can everybody online hear him?
Yeah.
Yes.
Okay, perfect. Okay, Nilesh. So what do we need to know?
All right. So these the proposed cuts were announced yesterday, and the governor's statement was around funding healthcare services delivery and childcare. But one of the cuts that what is on the table is a $12 million cut to local public health, to local health departments, which would represent about a 10.3% decrease in the core funding that local health departments get. That I say proposed because that's due to be voted on at the Board of Public Works next Wednesday. There are some other smaller programmatic cuts to delay the start of some positions, some delay in 988 funding, but that's kind of the big, the local health department one is one of the big ones.
Okay, Thank you for that information. And any questions from any, you know, we're all sort of just,
I did. Right. It's already zero.
Hey, Nilesh.
well,
I didn't think nothing more from nothing.
Sorry.
I mean,
This is
what's-
Nielsen. I have a question, but I think there's an echo in the background. Nilesh, can you provide some insights as to, you know, the rationale for core funding and why it's from local departments? Thanks.
So these are decisions that are made at the budgetary level. So I can't offer, you know, any reasons for why there were cuts across all of state government. So I can't really offer you any rationale.
Okay, thanks.
and just for the record, again, I'm going to put this to the sentence. LS represents, you know, the Maryland Department of Health. They in fact are, you know, part of state government. And certainly, we're not putting the pressure on you in LS to either have the answers for this. I think all of us, to be honest, from a commission's perspective, and I can say this openly, are disappointed and shocked over this. And certainly as private citizens, not necessarily as a commission, we have the ability to voice our concerns on this. I can find out, I'm not sure what that means from a commission's perspective, i.e., can a commission opine on something like this, a governor-appointed commission? I have to check with our legal side, right? You know, can we say anything other than to say that the commission, you know, we were quite honest when we began this whole process that at the end of all this, as we come up with recommendations, and the members of our commission who are from the legislative branch and from the executive branch representing the Department of Health all recognize that to a large extent, our recommendations are not going to come at a negative or a zero cost to the system. Now, we all know that balancing budget is a critical move in any organization, including that of government. It needs to get done, you know, at a state level, where there's comfort. The federal level has long, you know, gone beyond that. But to a large extent, you know, part of our goal, and I always remind this to the students that I interact with at the School of Public Health and to others that we in public health, despite news such as this, need to remain optimistic, right? That there are going to be, you know, the resources and to be able to for us to wisely come up with recommendations in place. But this was something we didn't want to just sort of not react to. This is all early on. Again, we received information as we're driving here, and my chair's prerogative was to introduce it here, at least for us to be as a commission to know about it. But read the news reports, read the stories behind it. I ask all commissioners to dig deeply into this and do what you think is right as an individual citizen between now and next Wednesday before the group meets, and I'll try to figure out whether we can do anything. Any other insight from anyone in the room? Fran?
Well, I don't know about insight, but I just wanted to express my sympathies to the last, that I've been in situations myself where there have been cuts in the past to these core funds from the state. And it's a very, very tough situation that he's in. And certainly that health officers are in, who are also state employees. So the interesting thing about that particular line item of funding, the core funds that the state sends to local health departments, there's a formula of that directs how much each town, each jurisdiction gets based on relative wealth and size and factors. That statutorily there is a match requirement for local governments. So if the counties and the city pull back their required match, that could double, in fact, the magnitude of the cut. Overall, it's a 50-50 match. I don't believe, I certainly don't hope that counts do that. And really the reality is we're already in FY with 2 weeks in FY25. So the counties have already made their commitment to local health departments. Unfortunately, the state can't maintain that commitment. But I know that this is an issue that health officers will discuss that. And Joe, David said it's a health officer. So at any rate, my sympathies, yeah, and to the health officer.
So with that,
Yes.
so with that in mind, let me be positive. Maybe that they're getting cut because there's. So, but I guess, is it possible to ask that the articles that you sent to us, so we can see the neighbors, send us the links?
We'll look into that. I would also recommend just Googling on your own, right?
Okay.
Because if you find anything substantive,
Sure.
I just did a real quick Google search and found one from YPR, right? And again, I think this is all late breaking news. I assume all the local health departments have been informed. Is that correct?
Yeah. We heard about it.
Okay. So, yeah.
What percentage of the budget does that represent? 26 million.
Question, Malesh, is what percentage of the budget does that represent?
I presume you mean of the local health departments, and we're actually compiling that information. So because they get other funds beyond what we know, I don't have the answer for you right now.
Okay, any other comments on this? Again, we will provide information. I mean, again, this is one of those things where, nobody wants to hear this news, and I do want to join on with what Fran says. Unless I know that puts you in a leadership position, in a very difficult position. To our local health department leads and members of those health departments, we realize, that is never good news. I know I'm not comparing this at all, but we at the university received a 3% budget cut on our programmatic dollars this last fiscal year. And that's a deemed the difficulty of rechanging, right? Ideas, plans, aspirations when you are, being, in essence, decreased. Yeah.
This is Tosin. I have a question in terms of what position we can take on this. And that might be to Nilesh. Are we able to draft a letter to the Board of Public Health in this case? As a commission, yeah.
Well, I think the difficulty is, and I wouldn't pose that question to Nilesh, because does this become a lobbying effort, and he is a member of the executive branch, shouldn't opine on that. I, as a state employee, even have some limitations in terms of that, right? Lobbying. What I think Tosin is going to be best is, one, I do encourage commissioners to reach out on their own and perhaps even use that you are a commissioner on the Public Health Commission. So whatever you have, you can, I believe, put that in there. I will check with our ethics and legal side of the house at the university to see how they want to advise anything. But the problem, of course, is signing anything from the commission denotes that there's agreement amongst all 16 commissioners, and to a large extent puts Nilesh and others who are members of the commission, who are in ex officio positions appointed, then it becomes a divided commission to some extent. Only some of us will be able to go sign a letter, and whether that is effective or not is a question.
Thank you.
Okay, let's move on now to our
I have another suggestion. So I'm Rosalie Bright. I'm on a working group. I'm not a commissioner.
Yeah.
I don't work for the state in any way. Maybe me and other people like me who are on working groups could join together and write a letter as people who are qualified to comment, but don't really have a conflict of interest.
Okay, well, thank you all for that part of a difficult discussion. I'm going to turn the microphone over to Shane now, who's going to lead the discussion in terms of updates from the commission. So Shane, take it away.
All right. Can you folks hear me in the room and online?
We hear you in the room.
Okay, perfect. you can go ahead and advance the slide for me. All right. So as we've been doing with the commission update portion, I wanted to highlight kind of where we are in terms of our timeline and the activities that we have coming down the pike here. In particular, I want to orient us to two things that I think are going to be pretty important for us to keep in mind. The first is that we will be shifting our discussion and having deeper conversations here shortly about the work that our work groups have been doing in the form of our deep dive presentations that begin in September. And I shared a draft of that template with commission members and work group co-chairs yesterday in advance of this so that we could start to have some thoughts and dialogue about what that template needs to look like and making sure that it hits on all the right points for the conversations we want to have. But this really will represent a shift in terms of the sense or feeling that to date we've done a lot of listening and ingesting information. Now we will be shifting towards having more analytical conversations and digging into the work that the work groups have done and outlining the various stakeholders that they've met with on their own, essentially all of the activities outside of the assessment work that will be underway here shortly, and I'll talk a bit about the assessment separately in a moment. You know, as with all of the materials that we share from the executive group, this is really meant to be the starting point of a conversation. That template certainly is not final, and we will definitely carve out some more time at a future leadership meeting to discuss that in depth, much like we did with the work group charter document. And what I think is really important about the deep dive conversations is that it will potentially be a great tool to kind of leverage for preparation of the final interim report, which is due in December of this year. So we will need to make sure that we have that prepared and ready well in advance of our December submission deadline. So expecting that around the November timeframe, we will certainly spend a significant amount of time discussing and at some point thereafter voting to adopt and submit that to the Maryland General Assembly and the other agencies that are statutorily required to be in distribution. Specifically, I want to make sure that all of our work groups and the folks participating on those are well prepared through the deep dives, as well as their relevant portions in the final interim report, that they're prepared to speak to health equity within their specific domains. At a previous leadership meeting, we had a lot of conversation about that under the guise of the work group charters, and noting that that really is not just a cross-cutting theme that statutorily we're supposed to discuss, but it really is the center of so many of the efforts that not only is this commission undertaking and studying, but in terms of work across the breadth of Maryland state government and other commissions and the Maryland Department of Health. So we need to make sure that we are honoring the work of the other state agencies and partners and reflecting that in what we do and how we consider moving forward in our recommendations, even with respect to the final interim report. I do want to make sure that as we're talking about the deep dives, that I'm very emphatic about this. Those are not those are not recommendations that we're putting into those. Those are really emerging themes that we're finding, or initial findings from the work that we've been doing. It's really premature at this point for us to be making recommendations since we have not yet gotten information back from the assessment and are still continuing to have conversations with members of the public through our public listening sessions and local health departments at the site visits as well as other system partners. So as we think about that, I encourage us all to continue to frame it in the way of initial findings that eventually lead to recommendations that will be reviewed by the commission and ultimately adopted. Next slide. All right. In broader updates, a bit of bittersweet news. Most of you are probably aware of this by now, but I wanted to make sure that we did right by Sarah Kulk and gave her true recognition for the work that she's done, both as St. Mary's County Health Department support staff for the commission, but also the work group coordinator for the governance and organizational capabilities work group. Sarah has departed from the commission and accepted an opportunity with the Centers for Medicare and Medicaid Services. It's going to be a really awesome fellowship opportunity for her. So as much as it stinks for us, very excited for her, and I fully expect she'll continue to stay involved, or excuse me, dialed into the work that we're doing, knowing that she's pretty passionate about this. So wanted to just really take a moment to recognize her and say that we appreciate her and the work that she's done. A bright spot on the horizon, though, with the turnover of some of our other work group coordinators, our partners at the CDC Foundation posted and have identified a candidate to fill a project manager role that will provide support to multiple work groups, as well as some backup support to Megan Roney, who's really been taking on quite a bit in terms of supporting the commission's work. So that individual is expected to start in early August after her vacation concludes, and we're really excited about bringing her on board and getting her up to speed so we can really make sure that as we start to get into the assessment phase of this work, we're hitting the ground running and operating smoothly. So my hope is that we have a bit of a lull in personnel transitions for a while we continue to wrap this up. In terms of upcoming things, as I noted earlier, we've got quite a bit of activity before the end of this calendar year, and I'm not going to belabor all of that again. But I did want to share that one of the things we're working on that's not really covered in that timeline is this support staff are working on developing a comprehensive communications plan that will help us ensure we've got a consistent message, and that is being woven through our social media, as well as reports and other releases that we're putting out. In that vein, it would be really valuable to hear from each of you what you believe is important in terms of the issues and themes as we move forward. And so in order to identify a cohesive and resonant message, I'd love to get some time scheduled with each of you, as well as the co-chairs, if they're available, to talk more about that in kind of a more one-on-one basis. So I'll be reaching out and hope you'll be able to take some time to have those conversations. Next slide. All right, we are now officially at the halfway point in terms of our site visits and listening sessions. We had a really great site visit at Howard County on the 13th of June. Dr. Rossman and her team really did a great job in terms of presenting information about how they're doing some really interesting and unique work down there, particularly with data-driven policymaking. After that presentation, we had pretty decent turnout at our public listening session, and had about 11 comments that were shared there. And those really spanned a variety of themes in terms of concerns about local health system capacity to needing more specific education for the public health workforce, including and especially nurses. So quite a bit of variety, and one of the things that really resonated with me in terms of public comment was one of the speakers asked that we be very diligent in sharing back with these communities what we ended up doing with their testimony in terms of the recommendations and what the result of this overall project is, so that they have the opportunity to hear more about that and engage with it. So I thought that was an interesting perspective as we possibly think about what happens after October of 2025, what we might do in terms of communicating that back to different constituencies. We do, of course, have 3 more site visits and listening sessions to go. I sent out the RSVP for Montgomery County and Talbot County earlier this week, and would love to get your RSVPs as soon as possible on those, so I can let the local health departments know who will be attending, particularly the site visits, but especially the regional listening sessions if you plan to make it to those. We'll be following up with more details. Essentially, those 2 site visits are set, and we're just putting final touches on things. I do still have some outreach to make with Baltimore City Health Department. Their initial date they suggested in September was not compatible with some pre-existing commitments. So we are looking at potentially moving that to October and finalizing that soon so that we can round this out and conclude the listening tours and site visits before the end of the year. Next slide. I believe we mentioned this briefly at the last meeting, and I know we talked about it with leadership and some of the work groups, but at this point, we really just want to do a bit more of an introduction on our assessment partners, particularly the academic entities that will be helping us conduct this work. So University of Maryland School of Public Health has been really deeply engaged in helping us craft the protocol. And from there, we have Dr. Amelia Aria, who is on Boris's team and leading this Strategic Initiative Center to shepherd this through. Of course, Tashanka will be working closely as a technical advisor and liaison between Commission as well as University of Maryland. We wanted to make sure that we had a holistic and comprehensive approach to this, though, and certainly as we talk about health equity, we need to make sure there's equity and representation. So excited to note that we have Morgan State University engaged as a partner on this as well. So Dr. Anita Hawkins and Dr. Kim Sidner will be joining us from that university, and of course, our own co-chair Tosin is on faculty and will also be functioning as a liaison and research advisor between those. So Tashanka and Tosin, I just wanted to pass it over to either of you in case you had more to add, or if you wanted to note anything that I might have missed on this piece.
No, I think you have it all said. Thank you. Nothing to add.
August to get to more specifics about the assessment process, and I'm very excited about the academic partnership and involvement of students as well in this process. Thank you.
Okay. That concludes, I believe, my portion of the updates, and so Boris, I think it's back to you for announcements.
Great. Well, thank you for that, Shane. Any questions from commissioners or group members to Shane? Yes, Fran?
I do have a question. Thank you, Shane. What is the approximate timeline for these sessions? We started in September, but I'm not sure how that's the case and how long.
At this point, the summer is going to be spent on developing the protocols, taking the questions and the suggestions from each of the working groups, taking a look at the overlap, and then creating and crafting the questions to the appropriate assessment mechanisms. So be able to funnel them into the focus group structure, into the formal interviews, stakeholder interviews, and then within the context of surveys that will go to local health department officers or other entities to complement those surveys that are already available. We'll be looking at that. So in terms of time frame, the fall will be the beginning. In some ways, we might be able to start some of the interviews in August, but it's sort of tricky in terms of accessing everyone. Focus groups probably in the fall, September and October. We're hoping to have some preliminary findings so that for the interim report, there's something to chew on and have those discussions. And I think the deep dives will sort of further feed into the assessment as well.
So the assessment will have, as I understand, it, survey, there'll be three mechanisms. Survey, the informant,
right?
That right?
Right.
Against which there will come all this, all the data, all the other resources that have been relevant that have been gathered, plus the work groups, that all that's together.
Right, and the public health wins, we will not get, we'll get the preliminary findings after the new year. We were told that in March, I believe, or at the end of February, if we're lucky. But that's one of the portions.
Just getting a sense of the enormous job.
I said that,
yeah,
I heard that the PH win might be further down in September, summer of 25. So,
okay.
that might be for the local health departments, not for, not for the push.
Now, we did hear that September 7th was a date that's a possible launch of public health wins. We can get more information. And, the intent is to get both the state and the local health department input.
Yes, Nicole.
Is there information that you can share with regard to the process for focus groups, how these individuals will be identified or what we're starting to think about in terms of who will be focus groups?
So that's a great question, and we've been looking at a variety of approaches. One is taking a look at the foundational public health areas. So those individuals who are active in the area of infectious diseases or chronic diseases or access to care that are being looked at programmatically across the state. So identifying those. The other is taking a look at some of the particular themes in the census, looking at issues of maternal and infant mortality, overdoses, the effect of COVID. And the third area is obviously the capabilities, which is really captured in the working groups. It will probably be a combination of those, plus within the local health departments, there's some naturally occurring learning groups and networks that keep up. And we may take opportunity of those. The epidemiologists get together, the public information officers get together, the accreditation leads get together, and they may have an opportunity. So the protocol is going to be looked at to make sure it's comprehensive in terms of getting representation from the geographic areas, from the urban rural areas, and then how to mesh it with the questions that are being asked by the interviews and also the questions that are being already available through the service. So if you have suggestions, this is a great time. We will be going to the IRB with the protocols in the fall. So we will bring a much more effective discussion in August before you so that you can review it and modify it.
I think my main concern is just with regard to equity, and one of the things that we talk about regularly in the communication public engagement is the idea that are we talking to the same groups of people? And there are a lot of people who historically don't complete surveys and things like that. So just, and I know it's difficult to reach, those who are historically considered unreachable without anyone that's unreachable. But it's really just to make sure that we're making a conscious effort to engage individuals who probably have not historically included in this conversation.
One of the things that we're doing on this another project is that we're looking at geographic matrix. I mean, the geographic demography of the area and making sure that the individuals we speak to reflect that. So, for instance, if we're in, a rural area, it's largely Caucasian, Hispanic, and maybe small percent African American, then that's what we do. If it's small African American group, small percent of African American or Caucasian or whatever, then that's what we do. And one of the ways that we've been able to do that is really working with like the maternal health. So they are community-based organizations that reflect that community that also understand the resources of that issue. So yeah, it's no question. It's more it is. But the results are overwhelming. Those have reflected even in terms of economics. So obviously for Georgia, where you are inside outside the Beltway. I mean, we just try to align our groups on small group discussion because we don't want to do it at home. I know the process, right? Are really reflecting and we've been able to bring community.
So both of those comments are outstanding. Communicate and as proposed, as you know, more of an informal outreach, which we're probably going to need help from the different working groups for some of this outreach because the concept was to go to local fairs, to local gatherings, and so having work group members that are distributed across the state, that type of information, which is extremely useful, but not controlled in the fashion of, so your point about getting a group together for a more casual discussion is extremely valuable. So that might be something as we look at the recommendations that each working group is making, there might be approaches that can complement that in order to get.
That's great because you're also talking about trust, right? Which is so huge. So that's awesome that you're. It also just the issue of equity and make sure that there's racial and geographic representation. Yes, have what we want to do. There's also the levels of so you've got the general community that may or may not be consumers, direct consumers of the health departments or knowingly, everybody's a consumer of public health. They may not be clients, but you've got the general public, you've got identified client groups, and I'm thinking right now behavioral health. You can't let that fall off, but behavioral health is. Then you've got the workforce. You've got people, public health workers, state. Then you've got leadership, and I wouldn't discount the opportunity to talk with senior county, someone in the mayor's office. Speaking from a governance point of view, I think that would be very valuable. It would also be fraught because these are sometimes politically sensitive conversations, and to get unreflected input in the protocol have some confidentiality or some kind of way of and maybe that's for all of us, some kind of sensitivity that people to have to maintain that trust. You need to have kind of Vegas rules
but also a feedback loop. So it's not just people coming in and writing thoughts and then we never hear feedback. So you can, yeah. Thank you.
All very good comments. Any comments from commissioners online regarding both Shane's discussion as well as the prelude to our August meeting, which is going to focus on the assessment specific? Okay. Any other items that any of the commissioners want to bring up at this point prior to my final announcements? Okay. We are still working, just as an announcement, for fulfilling the 2 open slots right now. And so the commissioner will reach out once again to the governor's office and to the legislature. One is a governor appointee to fulfill a local public health slot, and the other is from the Senate slot. So we really do want to get out to our full number of 16 as soon as we can. As happens with any bureaucracy, and I use that term lovingly, this is always a slow and sometimes cumbersome process. So we'll continue to push. That being said, our announcements really deal with our upcoming meeting. I think on at least some versions of the agenda, I just want to make sure you do correct the date. It's next meeting is August 1st. On some agenda items that were perhaps listed as August 2nd. It remains on a Thursday, first Thursday of the month. And so make sure you have commissioners have that for the rest of the year and then next year. We are blessed that we have new hosts here. It was a great run at Baltimore County Health Department. They were very kind to us for those 6 months. But we have now made a switch over to a new County Health Department. So we share our blessings with you. And also our thanks for a nicely hosted meeting here today. I overate on the Doritos. As always, I do have a weakness, and you Dr. may have found that weakness. I'll just say.
I'm sure that there are Doritos in everything.
Yeah, exactly. So that's not a good thing. So that's our next meeting. I think Nina is going to be back in town to preside at that. I will not be at that meeting. But we'll find the notes helpful. I may be traipsing around Mount Bluff around that time of the month. So yeah, hopefully that hike is going to be a successful hike. That being said, we also, as mentioned by Shane, please do look at the upcoming regional listening sessions and make sure those are on your calendars to be traded with commissioners. We're to be able to attend as many as possible. I know I personally have fallen off a little bit on my attendance because of scheduling issues. And so therefore, I thank you, first of all, to the commissioners present in this room, to our guests, to our hosts, to those online. I'm not sure if we broke the record today, but at one point we had 31 people online, which means that we are getting interest not only from fellow commissioners from the hybrid model, but also working group members, and we'll see what our list of outside visitors was. This commission only functions because of the volunteerism of each and every one of you. Both commissioners and working group members. So I can't thank you enough for what the time you're putting into this, the ability for us to progress as we have in these short few months. This is, I think, our 8th meeting, perhaps our 8th meeting, 9th meeting, somewhere along the line. But we are certainly making progress. We're getting information. I agree with you, Fran. At times it gets daunting, doesn't it? Begin thinking, but at this point, we are reaching the ability for us to say there is forward progress. We are, and have more information than we had when all this started. We perhaps have, we know we have a better focus on where we're heading, and yet that doesn't still take my breath away occasionally of saying, oh my gosh, there's so much more to do. But at the end, as I always mention to this group, we are on a bold and noble cause here, folks. It's for the good of the public's health. So let's remind ourselves that this is a bold and noble mission for us. I thank you for your attendance. I'll now ask for a motion to adjourn the meeting. Nicole moves. Who seconds? Second from Fran. All commissioners for adjourning, say aye.
Aye.
Anyone against adjourning? Anyone abstaining? Thank you all. The meeting is now adjourned at 4:51 p.m. Thank you.